بسم الله الرحمن الرحيم. أهلا بكم. أنا الأستاذ الدكتور عبدالعظيم الحفني Professor of Internal Medicine, Rheumatology and Clinical Immunology at Shams University. My talk today is about vasculitis. This is part 1. The intended learning outcomes. By the end of this lecture, you should be able to define vasculitis and give short notes on its pathophysiology, suspect and assess patient manifestations, enumerate the classification of vasculitides to primary, secondary, and the classification of primary vasculitis, as you will know. Interpret the clinical picture of common examples of vasculitides. Remember treatment outlines only. Know the proper time to refer the patient to rheumatology immunology consultant. What is vasculitis? Vasculitides are a heterogeneous group of systemic inflammatory disorders with demonstrable structural injury of the blood vessel walls, leading to ischemic manifestations due to vessel inflammation and narrowing. The possible pathogenic mechanisms: either immune complex deposition, anti-endothelial cell antibodies, anti-neutrophil cytoplasmic antibodies, and T-cell dependent inflammatory reactions. Lastly, infection of the endothelial cells. This picture shows the end result of the inflammatory cascade of the blood vessel wall, leading to inflammatory cell infiltration of the media, intima, and adventitia, the three layers of the vessel wall, and lastly, narrowing and thrombosis inside the vessel, leading to the later on the ischemia or infarction of the tissue supplied by this artery or arteriole. The initial assessment: how to establish the diagnosis. We have to look for the clinical features, then order laboratory tests to be the most sensitive and most specific available laboratory markers. Then to pass to the imaging, either plain X-ray or ultrasound or MRI or Doppler or duplex or angiography and so on. If we didn't reach the diagnosis, we have to take biopsy for the final diagnostic procedure. First, the clinical features. When you should suspect primary systemic vasculitis, the patient will be manifested by fever of unknown origin after exclusion of the common causes like infection and neoplasia, unexplained migratory polyarthritis, or mononeuritis multiplex, rapidly progressive glomerulonephritis and or palpable purpura and or diffuse alveolar hemorrhages, unexplained infarction in multiple vascular territories, unexplained multisystem disease. So it affects almost all the organ systems in the body. As we see in the picture to the right side, Behcet syndrome may affect CNS, may cause oral ulcers. Giant cell arteritis may affect the temporal arteries, as we will see later. Polyangiitis with granulomatosis may affect the nose, the upper airway, or the lower airway in the lungs, and so on. So these clinical features we will suspect when there is multi-system affection without localization. Then we have to order some lab investigations, and the principle here to trying to select the most sensitive and the most specific available tests. The laboratory work up, we have to do ask for ESR, C-reactive protein, acute inflammatory markers. We will suspect them to be high titer, complete blood count, and we may find anemia, leukocytosis without infection, and maybe thrombocytosis increased in the platelet count. Transaminases and the liver function tests may be affected also. Renal function tests, urine analysis, and albumin or protein creatinine ratio in urine, blood and sputum culture to rule out. Also, we have to order for antibodies directed against ANCA, anti-neutrophil cytoplasmic antibodies. They are two types, C or P. The C ANCA stains the cytoplasm, so it is called C. The main target of this antibody is against proteinase 3. It is highly specific, more than 90% for Wegener's granulomatosis or granulomatosis with polyangiitis. Also, the P ANCA stains perinuclear, so it is called P. The main target antigen here is myeloperoxidase. It may be present in Sharp-Strauss syndrome and MPA. Now, we have clinical features. We have some laboratory markers, but we did not reach the final diagnosis, so we have to order for imaging. The power Doppler and duplex may be helpful, or MRI, MRA, or MRV, also venous, arterial, or magnetic resonance imaging. CT or CT angiography may localize the area of stenosis or occlusion. PET CT, positron emission tomography CT also can be of help. The last item to establish diagnosis is the biopsy. Now, the biopsy, the last step in the diagnosis, we have to remember that the biopsy should be superficial, not harmful, not from a dangerous site, by experienced hands, and to be the last step if we did not reach the diagnosis before it. Histopathological evidence of vasculitis is the gold standard for the diagnosis. It is diagnostic step. The biopsy of the involved site, like the temporal artery, skin if it is affected clearly, there may be rash or ulcer. Muscle biopsy if there is a suspicion of affected the muscle. Nerve may be very superficial, sural nerve or something. The gut from by endoscopy from the stomach, from the duodenum, from the colon, from the affected site, and the kidneys. The renal biopsy in patients with active renal disease may show specific diagnostic lesion. And this is the end of the part 1 of this talk, and we will continue inshallah by the second part. And thank you.